So the first, we're talking about like the GS. GS, we need to understand like the GS package is the only package. There are no one brands have this package, only Smartee. It's a special package from mandibular repositioning for adults. So it's mandibular, not only mandibular advancement, so mandibular repositioning in facial prognativism or facial retrosegmentism as well. The idea for this webinar is to see my own cases and to review some cases from two doctors. They submit two different cases from two different kinds of approach, and we're going to make this like the more interactive. So I'm going to interactive, of course, with myself because it's very complicated sometimes online to make these interactive webinars. But I'm going to explain what is the ideal diagnosis and what is the ideal treatment plan with this diagnosis. So the first, we need to understand like the Smartee, this technology is only available with Smartee. So the GS is a special package for the corrective profile of the patient. At the same time, we can to move simultaneously like the teeth. So because with another brands, when you use like the mandibular advancement device, you cannot move like the tooth. They are behind of the aligners, or in this case, behind of the or under the precision wheels or under the blocks. In Smartee, you can at the same time doing like the mandibular advancement or mandibular repositioning with the mandibular advancement with the movement of the teeth. Everything at the same time. So we are going to go today because we have no time for to see all the different solutions that we have. But normally in GS they have three different special packages. So these three different special solution is the ACE-H, ACE-9, ACE-10. Today we're going to focus in the ACE-H. Is the foremandibular advancement. So this is like the, Professor Gang Shen is one of the, maybe is the one of the most, or maybe the most important orthodontic, the most famous orthodontics in China, and is of course one of the top 2% of the scientists globally. And with all the experience all of these years of the Professor Gang Shen with the GE systems, with the GE systems is treated more than 100,000 mandibular advancement cases in adults. This is very special because maybe in growing patients there are different kind of brands. They have different kind of solutions, but in Smartee is the only brand for we have two different kind of solutions for mandibular advancement. And in adults is the only system that have this special package. You have there three difference in the lower part of the screen. You have three different QR. For me the most important QR, of course the three are important, but the right, when the professor sends research paper, you have all the information about from the articles published by the Professor Ganshen during the last maybe 26-27 years, with the different articles, with science, with clinical cases, to show how you can correct this class 2 malocclusion using like from the beginning the professor started to use the twin block, the appliance for William Clark, and when the professor started to investigate and develop these devices with clear aligners to make the mandibular advancement. There you have a lot of articles. Of course, it's not possible to put all the articles published by the professor, but you have the most important article if you want to know or have more knowledge about these mandibular advancement devices. I know from the beginning it's complicated because I always explain that in my education I have from the old school, and I remember that my professors told me that it's not possible doing mandibular advancement, not even in adults. So in growing patients, if we pass the puberal growth, is not possible as well. And this is not true at the end, because you start to read these articles and you start to see that different kind of cases like the Professor Ganshin show you, and you start to use this system and you know that it's possible. In fact, today I'm going to show you two different cases with two different kind of approach, to show you which is the ideal in different kind of malocclusion. The other two QR are for the wax bite registration. This is, of course, because it's mandatory, and I'm going to explain later, because it's different from the malocclusion from the beginning, is different the wax registration. The wax registration is mandatory. It's very important. Why? Because it's like the position when the doctors, we want to put like our patient. So it's different. So from the beginning, we have class 2 division 1 or class 2 division 0 or class 2 division 2. It's totally different our wax registration. So there you have the registration form and the manual for make this wax bite. And of course, here in Smartee, we have two different devices. The HB is from Herbs Appliance, and TV is like Twin Block Appliance. This is like the diagnostic classification of malocclusion for pressure gangsheng is very amazing, it's very useful, but sometimes you need to understand everything. And I recommend you to learn about this and to study. But I want at the end to summary, because sometimes it's complicated, in which kind of cases we need to use like the HB, or which kind of cases we need to use the TV. At the end, the most important thing is the overbite. The overbite is like our maybe differential to use like the TV or the HB. If we have from the beginning, we have a patient with increased overbite, so we have as well normally increased curve speed, we need to use the HB, the TV, twin block. So repeat from the beginning, if we have increased overbite, so increased curve speed, we need to use TV, twin block. And from the beginning, we have like normal override, and we have this normal QSP or flat QSP, we need to use HB. This is the summary of all of this classification. This is the summary. Increase overbite, increase QSP, we need to use twin block, TV. We have normal overbite or no increase overbite, and normal QSP or flat QSP, HB. So let me show you one clinical case. This is Alba. Alba is 22 years old. And Alba was treated with an orthodontic treatment like around 6-7 years. And they have with normal devices. Normal devices is like the traditional one with braces. What happened here? I don't know exactly what's the problem from the beginning, because I know I don't have the register from the beginning, but I know what's the problem right now. I don't know if this class 2 is not corrected from the previous treatment, or maybe this class 2 is from the beginning and the doctor is not focused to correct this class 2, as only focused to align. I don't know exactly what happened. I don't know, or I know what happened is here. So the patient have two different problems. Of course, the class 1 or class 2 division 1 malocclusion with this increase overjet. And the second one, the patient has a tongue habit. You are talking with the patient, and the patient is talking with you, and every 4, 5, 6 words is talking something like this, and they put the tongue outside. So you're talking with her, and she put the tongue outside. So this is a tongue habit. I don't know if this is a relapse for the previous treatment with this problem with the tongue position, with the tongue habit, or maybe this kind of the malocclusion never correct perfectly. But you can see here like the art form is really good because it has a previous orthodontic treatment, but we have this problem. This is the picture of the scanner. We can see here like this complete class 2 malocclusion in both sides, more maybe in the left side than in the right side. In the orthopancreas, we can see we have the upper wisdom teeth, but we have agenesia of the lower wisdom teeth. I recommend the patient to make the extraction of the upper wisdom teeth, but the typical question from the patient, okay, doctor, you recommend the extraction, but it's mandatory the extractions? No, in this kind of cases, it's not mandatory, but it's a recommend. What happens sometimes with your patient recommend extraction, but you say it's not mandatory, the patient normally they prefer not to extract. So at the end, the patient, she doesn't to extract the wisdom teeth from the beginning. Okay, this is our cerebrography with the superposition of the lateral pictures. And we can see here from the beginning, we have this upper incisor, this pro-inclination of the upper incisor, and we have as well this little pro-inclination, this small pro-inclination of the lower incisor. And of course, our increased overbite and this retrognathia and this B retrusion profile. But this is one of the most important pictures, is the TMGs, the TMGs from the initial. So what happened here? We know like the central relationship, the definition of the central relationship is the position of the condyle in the position of more upper, medium, and the glenoid fossa. So we can see here like the condyle is not in central relationship. You can see in your right side, you can see it's close to be outside of the glenoid fossa. So this is very interesting because of course with 22 years old you have no pain, no problem, something like this. But this kind of position of TNG indicate that the patient have a class 2 like a class 2 like a skeletal class 2 with maybe in the future we don't treat this kind of problem. In the future the patient maybe should have problem with the TMG pains and some pain that they derive to the headache and sometimes from the neck or something like this. So it's very important to make this diagnosis and to see like the position of the TNG from the beginning. Okay, so what's my treatment plan? So I make a question. Of course, I'm going to answer myself, but I made you a question. We have from the beginning increase overbite. The answer is no. We have increased QSP. The answer is no. So our ideal device for this case is HB, Hertz. And this is the scanner with the wax registration. Of course, the wax doesn't appear in the scanner because you put like the wax and when you normally in the scanner, you start to scan. It doesn't matter the upper from the beginning of the lower arch. And when you have both arches scanned, you start to scan the occlusion. The occlusion, when you put the wax and you start the occlusion, the wax did not appears in the scanner. So in the TB, normally the Professor Ganshen, the recommendation in the HB normally is to finish like H to H contact. Right now, I am applying like the same philosophy of the Professor Ganshen with the TV, with the twin block in the HV. Why? You can see later that this H2H contact sometimes they produce with in a class 2 division 1 when you start to retrocline the incisors you create an anterior contact and sometimes you have no enough space to make this ideal mandibular advancement. So but the ideal is H2H contact, and you can see here this class near from class 1 in both sides. So this is our grass registration. Okay, and this is our treatment plan. Our treatment plan, normally in the GS package, you are going to see like from the first between 3-6 aligners, the first 3-6 aligners, there are aligners that normally they come in twice. The aligner number 1A and 1B. 2A, 2B, 3A, 3B. Why? Because normally, and this is very important, when you are using the GS from if we want to take like the real effect, it's mandatory to use the device during mealtime. It's mandatory. This is not negotiated with the patient. This is very, very important. Why? Because during mealtime, all the force of the chewing, all the force of the muscles, all the force are very important to produce this condylar remodeling. So in adult patients, one of the things that is very important is like the patients need to eat with the device. And this is no negotiate with the patient. With this is one of the very important things. This is the difference if your case your treatment plan is going really good or maybe it's not good. So very important. And what's happened? These three or between 3 until 6 aligners, the first aligners, the patient is not comfortable. It's very uncomfortable because they need to eat with this. And from the beginning, the patient have this kind of movements that not natural movements, and sometimes the patients maybe they should break like the blocks or should break like in that case the HB the wings. So these two aligners per stage is important because the first 3 or 6 stage is to change every 10 days, ideally every 10 days. So for example, my protocols is you have the stage number 1, A and B. So I prefer to say to the patient, okay, you're going to use the stage number 1A 5 days, B another 5 days. So 10 days in total. The first phase, you can see here the first six aligners, the change is every 10 days. Every 10 days, is aligner 1, A, 5 days, B, 5 days, and using during meal time. When you start aligner number 7, you can see here aligner number 7 start to put like the rest of the attachment. From the beginning there, normally they put only 4 attachment in the upper, 4 attachment in the lower to have more retention for the aligners. But since aligner number 7, the system put like the rest of the attachments, and start to move at the same time mandibular advancement with the moving the teeth at the same time. Of course, the most important thing is all of this is only the mandibular advancement is only in one step. It's not like in Invisalign they're doing like every 8 aligners is 2 millimeters of mandibular advancement. No, the ideal and the Professor Ganshen philosophy, and if of course it's like the philosophy is working really good, is only one step. Of course, be careful if you have a patient with 14 millimeters of overjet. To make only one step 14 millimeters, this is crazy for the patient. It's very uncomfortable. So sometimes you need to make this mandibular advancement from the first stage from 7 millimeters, and when you have the remodeling of the condyle and you have the new position, maybe you have another step with another 7 millimeters. But this is for special cases. So normally in my protocols, the patient has 10 millimeters of between 10 millimeters of overjet or less is only one step. And you can see here, we are using 3 different kind of devices. The HB, of course, you can see here like this blue area in the buccal surface of the lower incisor. This is the lip bumper solution. The lip bumper solution is ideal to avoid the pro-inclination of the lower incisor. So this is one of the most unwanted effects with the mandibular advancement. When you make this mandibular advancement, normally you have like the secondary effect is the pro-inclination of the lower incisor. So use this kind of devices, this lip bumper, is to avoid the pro-inclination of the lower incisors. And the another solution you can see there in the lingual surface of the incisors is the tongue crib. The tongue crib is to correct the tongue habit. This is important not only for the aligners, so in this kind of case, even the patient is adult, normally if the patient have a habit, a tongue habit, normally I send to the therapist, the tongue therapist, because it's very important to correct the habit. Why? Because if we start to correct everything, like the class 2, the open bite, the overbite, everything, if the patient continues with the habit, all of our treatment, what happened? The patient, I think totally 100%, the patient will have a relapse. So it's very important to control the habit with this kind of devices like the K3, like the tongue crib, and of course we support with the work of the tongue therapist. This is the patient, aligner number 18. So you can see here how it is the 3 devices, the HB, the lip bumper. And the lip bumper is a solution that you have in the Smartee. So of course this is the integrated in the aligner, and you can use in both arts. In the lower arch is to avoid, well, the function is the same, is to optimize the anchorage and to avoid the pro-inclination of the lower incisor, but you can use in the lower arch, for example, in these kind of cases, in mandibular advancement to avoid the pro-inclination, or even you imagine you are using like a growing patient, and you are using like another solution that we have in Smartee, we're talking like the last webinar, is the S16. The X16 solution is the combination of the S11, it's like this transpalatal arch for the expansion, with the S15, with the Smartee buttons, to use for a facial mask. So one of the unwanted movement we can use the lip bumper in the upper arch as well. So in this case, we're using the lower to avoid the pro-inclination. And the other solution is that one, is the K3. In the Smartee, we have 2 different solutions for the tongue habit, the tongue protrusion and the tongue crib. The tongue protrusion is ideal for the patient that have an incorrect shallowing, the position of the tongue when the patient is shallowing. So it's the ideal because they put the tongue in this spherical protrusion and put the tongue there and start shallowing to improve like the movement of the tongue. The second one is the tongue crib. This is pyramidal protrusion, is in this case to correct the tongue habit. Okay, this is the patient, aligner number 18. You can see here in the right side, we are close to the class 1 malocclusion or class 1 occlusion in the molar. still class 2 in canine, and we have incomplete class 2 in the left side, molar and canine. This is the scanner, ortho, and telegraphy. And you can see here we start to retro-incline the upper incisor. And right now, our overjet decrease. We have still overjet, but we decrease. And the profile, we're improving the profile as well. And this is the patient aligner number 40. It's the previous from the refinement. So what happened here? In the right side, we have the class 1 or super class 1 or near class 3 molar. Perfect class 1 canine, but in the left side, what happened? We have still class 2 canine and near of class 1 in molar. The problem is we don't have overjet. We correct a lot the overjet, and right now you can see here on the blue paper that we have contact in the anterior area. This is one of the reasons that right now the mandible we have the different, no? From the beginning until right now the midline are center, and right now it's not center. Why? Because maybe this anterior contact they not allow to me to correct perfectly the malocclusion. So this is not a problem because with the refinement we can to correct the very easy way, but it's very important. So right now, why in class 2 division 1 in my wash station, normally I prefer to leave 1 or 2 millimeters of overjet when I make this mandibular advancement. Why? Because I need to, in order to think in the future, to retro-incline the upper incisors and have enough space to the retro-inclination of the upper incisors. This is the orthopantomography, and this is the teleradiography. And you can see here, like the ideal situation of the angulation of the upper and lower incisors with the skeletal bone. And we take like this the radiographic, facial, and dental comparison. Of course, in the orthopography, it's not a lot of changes because it's like the similar, but in the cephalometric, we have the aligner, the initial aligner number 40. So what happened here? We retro-incline the incisors, the upper. We retro-incline the lower incisors. So indeed that case, like the lip bumper works really good because we retro-incline the incisor. Not we avoid the pro-inclination. So we retro-incline the incisor, okay? Because we use both like the lip bumper, and of course we make a little IPR to have this little pro-inclination to make more mandibular advancement. This is like the superposition of the mandibular, and right now this is the morphing of the position of the mandibular. This counterclockwise rotation. And this is the profile. So this is B-reduction profile. Right now we have a very better profile. This is the situation, the initial and the aligner number 40. And this is the best for me. This is the best of all the pictures that we have in this presentation of this case is that one. What happened with the TNG? With the TNG happened two things. The first one, right now the condyle is in the central relationship. Right now it's in the ideal position inside of the gland fossa. And the second one, the remodeling of the bone starts. Right now you can see here inside of the red circle how it's starting the remodeling of the bone. But the situation of the condyle inside of the gland fossa, this is the most amazing. And of course, this is not magic, this is science. And this is one of the articles published by the Professor Gangshen in collaboration with the University of Sydney. And you know, the doctors know, like normally the craniofacial bones, normally the growth is like the upper and backward. But the displacement is like the lower and forward from the depression of the sutures. But this is the same. So if you make this orthopedic pull force and you're moving the condyle, you're moving like down or lower and forward, the viscoelastic force they make to the remodeling of the bone to make like the upper and backward. And it doesn't matter the age. It doesn't matter. It doesn't matter is like the 9, 10, 15, 25, 35, 65. Of course, we need to understand every patient, and all the patients are the same. And sometimes to put like this kind of mandibular advancement with an increased overjet in a patient with 68 years old maybe we can to complicate the lifestyle. So sometimes maybe the patient with the oldest patient that they have with this GS package is 53 years old and is working really good. But normally you need to understand every case. So, and we have another clinical case. This clinical case, this is like the Alejandro. Alejandro was coming to my office, and you can see here the same, no? This biretrusion profile, this retrognathia of the mandible. And what happened in the intraoral? The problem with Alejandro is this patient was finished the treatment with in another clinic with an Invisalign 6 months ago. 6 months ago. And the patient come to say, okay, Dr. Vicente, I treat with another doctor in another clinic, but I'm not happy with the results because I feel that I not eat really good, but I don't feel comfortable. I feel it's not finished really good. So at the end, the same. We cannot talk about this is bad or good treatment because we don't know what's the agreement between the patient and the doctor, because maybe the doctor, they say, if the doctor doesn't know they have this kind of package to correct the class 2 malocclusion without extractions, or in that case without surgery, the doctor, they say, okay, in that case, maybe the only thing that we can do is align the teeth and to align, have a improve the occlusion and less more. So it's very important to always, from the beginning, in that case, talk to the patient, okay, we can to correct this kind of malocclusion without surgery, but it's very important. You need to use like the device for 24 hours per day. So you need to use during meal time. You are going to remove only when you finish to meal the meal. You're going to brush your teeth, you're going to clean your device, and you could put again 24 hours per day. This is mandatory. Okay, this is the scanner from the beginning. In that case, I understand and I learned from my previous previous patient, and right now they have the same problem. We have the wisdom teeth in the upper arch, no wisdom teeth in the lower. So right now I say no recommendation. I think it's mandatory to extract the wisdom teeth, and the patient do this, make the extraction. And you can see here like the condyle is different, totally different, like the position and the structure of the condyle in the right side and the left side. The condylar path in this case is similar, it's different. So you can see in the left condyle, this condylar path is more vertical, and in the right side is more horizontal. So it means that in the left side, maybe it's the chewing side, because this is more vertical. And in the right side, it's more horizontal, maybe it's the balance side. Okay, this is like superposition of the cephalometric. It's a class 2 division 2 malocclusion. So, which is my treatment plan? So the same. I know that in that case I need to use mandibular advancement. So mandibular advancement, we have two different devices, HB, HERBS, or TB, Twin Block. So remember again, from the beginning, I have increased overbite. In that case, yes, I have increased overbite. I have increased curve speed, maybe a little. So in that case, my ideal solution is the twin block appliance. And this is very important. This is the wax bite registration for mandibular repositioning. And from the beginning, we need to understand two different things. The first one is the sagittal direction. If we have from the beginning a class 2 division 1, is very important. We talked that before. It's very important to make this mandibular advancement with the wax registration and left at least 1 or 2 millimeters. Why? Because I need to retroincline the upper incisor. So in class 2 division 1, my wax registration is made this mandibular advancement and left 1-2 millimeters. In class 2 division 0, for me class 2 division 0 is when you have the ideal inclination or the incisor are straight with the skeletal bone. So in that kind of cases, you can make this edge-to-edge contact for the wax registration. But what happened with the class 2 division 2? In class 2 division 2, the upper incisors are retroinclined. So if you make this edge-to-edge contact, what happened? In the future, when you start to pro-incline the incisors, you are going to finish with increased overjet. So the ideal is in this kind of the kind of malocclusion is to finish or to have the wax registration with near from 1 millimeter of anterior crossbite in order to pro-incline the upper incisors during the treatment. And the other important thing that the TV in the twin block is the vertical direction. The vertical direction is the vertical distance of the posterior teeth. Why? Because the professor Vicente said it's very important to left at least between 4 or 5 millimeters. Why? Because you need like the space for the construction of the blocks. This is very important. So in the posterior area, you need to left 4 or 5 millimeters. So you can see here like the anterior teeth seldom be opened vertically. If the vertical distance of the posterior teeth area is less than 4 or 5 millimeters, the anterior teeth should be properly open. Don't worry about it. The most important is not the anterior contact, is to left in the posterior area the open bite for 5 millimeters. So for example, this is the patient with the wax registration. The wax registration, is in the posterior area. We have these 5 millimeters of open bite, and this is my scanner. So you can see it's edge to edge or near from anterior. Here you can see a near from anterior crossbite, but it's important to have this anterior open bite. It's not important. The important thing is the posterior area. Why? Because if I finish maybe with anterior contact in the posterior area, maybe I have 3 millimeters, 3 millimeters and a half. And what happened? Smartee, they are going to reject my wax registration because it's mandatory to at least have 4 or 5 millimeters of posterior open bite. This is the photos of the patient with the wax, and this is my ideal profile that I want to achieve. And this is my treatment plan. The same. You can see here the first 3 until 6 aligners is only for the mandibular, like the mandibular repositioning for the beginning. The patient needs to eat or need to use during meal time. So it's very important to eat with the device. So right now I'm using only one kind of device. In that case, the ACE TV. The other thing that you can see here is very important is that one. In the left side, at the same time that we're moving this mandibular forward, we are distalize the distalization of the molars. So what happened? Everyone knows that we are going to distalize. Normally, we need to use like the anchorage. The anchorage normally is or use elastics, class 2 elastics, because for the Newton third law, when you apply a force to distalize, in that case, you have another force on the same quantity, then they move the mandibula or they push like the teeth for the anterior teeth forward. So normally we use like the class 2 elastics to avoid this force. But what happened here? We have the blocks. So the blocks is the ideal because the blocks, they help me to neutralize the force of the Newton third law. So at the same time, we are the distalize, and my anchorage are the blocks, because these blocks the patient is using 24 hours per day. So you start to distalize, you have this force, and the other force, they make this, they have removed this force from the blocks of the twin block. So it's ideal for this kind of cases. You want not only mandibular advancement, so at the same time you can to distalize this teeth. It's one of the in this case, what the recommendation I say to the patient to extract the wisdom teeth, because I want to distalize at the same time to make mandibular advancement. And this is the patient aligner number 30, exactly in the pre-refinement. So what happened here? You can see we have this posterior open bite and this anterior contact. This is normal. In fact, this is one of the reasons that our treatment plan is working really good. Of course, the patient is not comfortable, but I explain always from the beginning to the patient. You need to use during meal time. From the beginning, you are not to feel comfortable because eating with the bites is not like that. It's not comfortable. But at the end, from the beginning is a problem. At the end is a solution. Why? Because the patient, you can see here this posterior open bite. What do you think if the patient wants to eat, for example, like meat or a fillet or something like this? They have no contact. So the patient needs to use the aligners with the blocks to eat. So the patient finally, or normally maybe at the aligner number in the middle of the treatment, the patient, when they remove the aligner, they feel they have no contact. So they prefer to eat with the aligner. So from the beginning it's a problem because very uncomfortable. At the end is a solution. So the patient feel more comfortable eating with the aligners with the blocks. And this is like the scanner for the pre-refinement, the orthopantomography. You can see here right now the condyles are more similar, so the condylar path right now is not perfectly, but are more similar in both sides. And this is like the superposition of the cerebrography. And we take like the comparison from the beginning in the orthopantomography and in the telegraphy. You can see here two different things. The first one, we increase the airway. This is very important because like sometimes the class 2 malocclusion, the retrognathia of the mandible, normally they make this small airway and the patient have problems with the apnea. So here with this mandibular advancement, we increase the space for the airway. The second one, of course, we improve like the profile, we improve the like the in this case like the mandibular retrognathia, and of course we have a little preinclination of the lower incisor. I want to this kind of preinclination is not bad. Of course, if I like to avoid all the preinclination, I use the S2 solution, the lip bumper. But in that case, I prefer not to use. And this is like the superposition of the initial and the pre-refinement. And you can see here the profile from the beginning. In the middle is the profile with the wax registration, so my ideal profile. And in the right side is the final pre-refinement. So you can see here it's very similar. Like the middle is the ideal profile with the wax with the final situation pre-refinement. Okay, initial aligner number 30. All of this in 30 aligners. Remember, the first 6 aligners is to change every 10 days. So you have twice. So normally A 5 days, B 5 days. So since the aligner number 7 need to change every week. So at the end, this treatment is near from 7-8 months. So it's really good. Beginning, pre-refinement. See the difference of the position. Of course, we change like the art form, the position of the mandible. And this is my refinement. So I don't need to think about or to feel crazy to start to use like the buttons, elastics in the posterior area to close this posterior open bite. No, because the problem that I have here, this is anterior contact. So I need to change like the torque of the incisors. I need to change like the inclination of the incisors in order to remove this anterior contact, and the mandibular only with the attachment is enough to make this extrusion of this natural eruption, because it's not extrusion, it's not high extrusion, it's only changing like the position. And the mandibular, with you correct or you remove this anterior contact, the mandibular is step by step is like this counter close bite, more movement and improving the occlusion. So in some cases with GS, it's not necessary sometimes use the elastics and butter in the posterior area, but some doctors they feel like they are afraid because this kind of posterior open, they think, oh my god, this posterior open bite is very complicated to correct. No, it's very easy. It's like natural eruption because we are changing the occlusal plane, and this is very easy. Of course, in some days you need to use button elastics. Of course, it's not all the cases, it's not the same, but don't be afraid. This is normal, this posterior open bite, and it's very easy to correct. So thank you so much. This is to present my own cases. If you have any questions of that presentation, please you can to write to the chat group. And if we have time, we're going to share another cases from two doctors. Anyone? Any questions? No questions. Can you show us how you set up the Smartee check? Do you want to show like the setup using like the how to manage the Smartee check? So how to use the Smartee check in this kind of cases? Close posterior open bite. Yeah. Let me to show you again. This is how to close. You can see here. Right now, I'm doing extrusion with the only with the attachments. It's not necessary from the beginning. It's not necessary like the buttons. The second one, I need to create overjet. Why? Because I need to correct. So of course, here you can see at the end, this is this virtual jam, this vertical virtual jam. Of course, every virtual jam is the name, is virtual, it's not real, but they give you an idea the how it's going to correct. So the most important thing is the first is to remove the anterior contact. So in that case, we say from beginning class to division 2 is to increase like the torque of the teeth. The second one, I'm doing like the asymmetrical IPR to center the lower midline with the upper midline because the upper midline is centered with the facial midline. So in this case, I make this asymmetrical IPR to center the lower midline with the upper midline. And of course, I use the same IPR to increase the overjet. And increasing the overjet, what happened? So step by step, of course, not only one step that the virtual jam, step by step, the mandible is going to improve like the occlusion. And the posterior area, you can see here, I'm doing the extrusion of this natural illusion with the attachment. From the beginning, I repeat, it's not mandatory to use button elastics. Maybe if I finish that case, imagine when I finish, I have contact in the premolar area. I have no contact in the anterior area because it's very important. No contacts in the anterior area, canine to canine. If I still have this posterior little open bite, okay, in that cases, I start to use or I change my attachment with buttons and elastics. I would like to see the comments to the left initiation to develop the version of the treatment plan. Thanks. To develop the versions of the treatment plan. For example, what specific instructions do you give to the technician, like sequential distalizations together with mandible management, choice of attachment, any overcorrection to problem? Yeah, every case is different. Normally, like the good thing that we have on Smartee is we have a very good technical team. And sometimes, for example, the doctors from the beginning, when they start to use like the Smartee, they feel overwhelmed. Why? Because we have a lot of solutions. You know, the S1, S2, most of the solutions are integrated. You don't need to ask. But for example, you have a case, imagine a case, and you don't know if that case is a special from TB or HB. So you have you make the, of course, you watch restation, but you know exactly what kind of device is ideal. So you can to write to the technician, dear colleague, please, I have done with this case. I don't know exactly what kind of device I need to use. Please, can you help me? And the technician and medical team, they say, okay, dear doctor, in this kind of case, we recommend you like the twin block appliance because you have from the beginning this increased overbite, this increased creep speed. As well, we recommend you to use the S2 device, the lip bumper, to avoid the pro-inclination. And the distalization is the same. The sequential distalizations normally is 1/2 is the normal one. It's not applying the 1/3. 1/3 is special for another cases, but this apply the sequential is automatic. There is some cases for some cases like for example a case that the doctor summit. If we have time, we're going to say if you are from the beginning, you have like the lower incisor is a lot of pro-inclination. Sometimes, and this is very complicated sometimes to understand, if you have the lower incisor from the beginning is very high pro-inclination, sometimes you need to use, like then to extract the lower wisdom teeth, use mini screws buccal self, distalize the lower arch, to retro-incline the incisor and to increase more the overjet to improve the mandibular advancement. And this is in special cases, but you have from the beginning this very high pro-inclination of the lower incisor. So it's very important that of course in every case you need to customize, no, it's different, but don't worry because normally the technical and medical team always is there for helping you. And some cases they're going to say, okay doctor, for example in my cases, no, they are going to load a case and they say, okay doctor, in this case we recommend you to make these self mini screws buccal self to retro-incline the incisors. I say, okay, thank you so much for recommendation, but the patient declined the mini screw. So I'm going to retro-incline the incisors using like the IPR or with the S2 solution, but not using like the buccal self and the Smartee hook. So every case is different. Okay. Doctor, okay. Question from Silvia Lim. Hi, Professor Vicente. May I clarify when you say 10 days were first 6 sets of aligner, on first 6 sets, then were 5 days for A and B? What does it mean? Exactly. In the first 6 aligners, normally Smartee provides you twice aligners per stage. Is aligner 1A, aligner 1B, aligner 2A, 2B. So in the first 6 aligners, you have twice in every stage. So what happened? The patient can use only during 10 because the ideal like the wear time is like 24 hours. And the duration of the to change the aligner, the first 6 aligners, the recommendation is to change every 10 days because the patients need to make the adaptation of the neuromuscles for the new position of the mandible. So the idea is to change every 10 days. There are patients, they maybe they need only to use the 1A for the 10 days, but normally, in my experience, about the day number 5 or 7, sometimes when the patient is not comfortable from the beginning, like the blocks or the wings, they start to broke. And when it's broke, you have another pair. You have the 1B. So my idea at the end, when you have both, you have twice, the ideal is, okay, you need to change every 10 days the stage number 1. So the ideal is use 5 days aligner number 1A, another 5 days aligner 1B. But of course, the patient can use only aligner 1A for all the 10 days and don't use the aligner 1B. This is like what I want to mean. Jaden say, in a case with middle desviation, do you take the wax bite with the dental midline considered or skeletal midline considered? It's a really good question, doctor. Normally, the most important thing is not normally we have the upper midline. Of course, we need to center with the facial midline. But normally, the lower midline normally is with the chin, center with the chin. But if you need to choose between the midline of the dental midline of the skeletal, you need to try skeletal. Why? Because it's most important you have the chin center with the facial midline, and if you have a little deviation of the lower midline of the dental midline, don't worry, you can to correct, but it's most important. But of course, you need to be careful with this patient of deviation. But if you have a very high deviation, maybe the treatment plan is not only with the GS. Maybe in some cases they need surgery, of course. But if you have a little deviation, the most important, of course, is the skeletal midline. Skeletal midline is in the upper, normally is like the max, and normally is the upper midline, and in the lower is the chin. Okay. So I'm going to show you that case. To give me 1 second, I'm going to share that case. That one. Okay. That case is for a doctor. And this is the doctor. Well, you know that in Smartee we have this amazing tool is the oral health report. In the oral health report, you can to upload the pictures of the patient, the cerebrography, the orthopantomography, and in 3-4 minutes you have all of this report from everything. So we're going to go to the. Give me 1 second. Okay, this is like the orthopantomography. So normally with the AI, identify all the teeth, the mandibular nerve canal, if the patient have the size of the condyle, the maxillary sinus, the impacted teeth, and maybe from the restorative crowns or root canals or fillings or everything. Everything is automatic. In that case, the doctor upload the case in this case with the pictures of the scanner. My recommendation normally is to upload with the pictures of the patient, the photos of the patient, not the scanner. So we have here this class class 2 malocclusion in the left side and class 2 malocclusion in the right side, left and right. Okay, this is all the reports. You have the periodontal disease, abnormal color. Here you can see the root canal, like the crown. So you have all the information about everything. And of course, you have the cephalometry. You can see here, this is one of the reasons. You can see the profile. The profile is the patient have this retrognathia, this class 2 division 1. So what happened with the lower incisor? The lower incisor is proncline from the beginning. So if we want to make this mandibular advancement in that case, if we start to directly start to make the mandibular advancement from the beginning, what happened? The lower incisor, even using the ST solution, maybe it's maintain the same position or have more pro inclination. So the ideal in this, if you upload this case to the Smartee, clinical team and medical team, then normally they are going to write you, dear doctor, in that case, we recommend you to extract the lower wisdom teeth, use a mini screw self, so the buccal self, distalize the lower arch, so increase the class 2 malocclusion in order to retroincline the incisors and to create more overjet to proincline, to make this mandibular forward, to improve the profile. And you can see here, this is very, very close, like the angle of the labial chin angle. So this is very important. So in that case, you make only mandibular advancement. What happens? You finish like the lower incisor proncline. The profile should be finished like maybe like this, or maybe you improve a little. But if you retroincline the incisors, and of course to retroincline the incisors, you need to distalize the lower arch to increase the class 2, and increasing the class 2, dental class 2, you have more space for this mandibular advancement. So this is a very interesting case, complex case, very interesting case, of course. But you can see here, of course, you have like the quantitative analysis from the bone age analysis, and you have the airway and the patient like the front smiling, the analysis, and you can see here, for example, the patient have the center, the upper midline is centered with the facial midline, and this is the lower midline is have a little deviations to the left of the patient. And everything you can see here is automatic with the oral health report. Chin retrusion, of course, the lips. So this is like the smiling simulation. Okay, this is of course with AI, and this is like the VTO. The VTO is not, of course, it's not perfectly. And the last, maybe you have here like 30 pages. The last normally 10 pages is to explain the patient, which is overbite, which is like the what is deep overjet. So to explain the patient, because this oral health report is very useful, because you only you need like the photos of the patient and the orthopantography and teleradiography, and with all of this you can to upload in the Smartee platform in 3 minutes, 4 minutes. You have your oral health report, and you can to share with the patient this PDF. So they say the patient, okay, oh my God, and this kind of oral health report help you for the diagnosis, because you have here a lot of information, and of course help to the patient to understand the problem. They say, okay, oh my God, yes, I have a lot of problems. So you can see here. So in that case, is of course it's complex case, but my recommendation in that case is, okay, extract wisdom teeth, mini screws buccal self, distalize the lower arch, the molars, all the lower arch. If you are using like the skeletal anchorage, you need to apply, for example, you want to apply like the 1.5 protocol, perfect, but you can apply 1/3 protocol. Why? Because you have a skeletal anchorage. With a skeletal anchorage, like the protocol, you can move faster the teeth. Faster is not more than 0.25 millimeters is the ideal. You can move like you start to move the second molar, and the second molar will have the 1/3 of the movements than with the first molar. And I have friends, they move at the same time. So everything at the same time. Why? Because you have a skeletal anchorage. But the ideal is to apply 1.5, 1/3 protocol. So you increase your retroinclined incisors, and when you have more overjet, you make this mandibular. All of this you can do it at the same time. You don't need to wait until to start like a pre-phase of mandibular advancement. You can start from the beginning using like this distalization of the lower arch at the same time. So that case has increased from the beginning, has increased overbite. so increase screw speed. So the ideal in that case is use the twin block device. So we can, from the same time, make this mandibular advancement with a twin block. At the same time, we are distalize of the lower arch to in order to retro-incline the incisors with these vocal self mini screws. So I don't know if I explain with this case because it's a complex case. I hope I explain good because it's complicated sometimes to understand in a class two, distalizing the lower arch. But in that case, it's mandatory because the other option is, or maybe doing a lot of the IPR is the patient reject to use like the mini screws. Maybe the only option is to make a lot of the IPR from mesial to mesial of molars, a lot of the IPR in order to align the teeth and retro-incline a little and make this mandibular advancement. But the ideal to improve more the profile, because the patient have a, for me, the best thing we need to improve is the profile. We need to retro-incline and make this mandibular advancement. Okay. Sylvia say, thank you. Also, may I check it's normal that the recommended distalization by the Smartee technician does for upper and lower together? Is we need to highlight to them only distalize one arch with class 2 elastic results is better distalization. If you want to distalize at the same time upper and lower, normally you need to use maybe two different protocols. If you want to distalize at the same time and in both sides, you need to use mini screws. You need to skeletal anchorage, because with skeletal anchorage you need to distalize both in both arch in both quadrant. But imagine you want to distalize in one quadrant in the upper arch, in one quadrant in the lower arch, you can use like the intra-arch anchorage. Intra-arch anchorage using the rest of the arch, the rest of the teeth, like anchorage, to make this distalization. Normally, if you distalize the upper arch, the anchorage, of course, with class 2 elastics, it's like the class 2 elastics is not to like the to distalize. Is to, in this case, to remove like the force of the sorry, of the Newton third law. Is the theory you have is like you're going to distalize the upper, so you have another force to pro-incline, and you use these class 2 elastics to make everything to go back. It's different. Every case is different. But normally, if you want to distalize all the quadrants at the same times, you need mini screws or intra anchorage. Start to distalize in one side, second molar, first molar, in the other part, in the other side, second, first molar, and you start premolar. So you need to play with the different anchorage. Bart says, hello, Professor Vicente. Sorry, I missed most of the webinar. Maybe it was already a topic, but there is question. Sometimes I notice incisors in bite reposition scan are open. Is this get the 5 millimeters bite open in posterior for the HGTV version? Yes, exactly, doctor. This is like the question. I explained in the webinar. Of course, if we need like in the 5 millimeters in the posterior area, sometimes if we finish this edge to edge contact, we don't have this enough space. So sometimes we need to have an open bite, like a full open bite, posterior and anterior. But the most important thing is the 5 millimeters in the posterior area. So if I need to achieve this 5 millimeters from the posterior area, if I need to finish in this wax station in a little open bite in the anterior area, is mandatory. So this is the important thing. Always we need 5 millimeters in the posterior area.
I think that's for all the questions. Thank you so much, Dr. Vicente. It's always awesome.
It's my pleasure. It's my pleasure. I think we don't have more time, so maybe we can to finish here if the doctors have no more questions.
Yeah. Have a good day.
Okay. Have a good day, everyone.
Bye.
Bye.